Good morning, Bacho. Good morning. Welcome. Today's topic, well, it's one you are going to face every single day in your practice, no matter where in India you end up. This is a battle we have been fighting for generations. We're talking, of course, about anti-malarial drugs. Chalo, let's begin. You see, for us, malaria isn't just some chapter in a textbook, okay? It's a massive public health challenge. It's a daily clinical puzzle. And it's the story of a constant arms race between our medicines and a very, very clever parasite. So I need your full attention today.
So before we can even talk about the weapons, we have to understand the enemy. The villain of our story is a tiny organism called Plasmodium. But it's not just one villain, it's a whole family of them. A proper gang, you could say.
Now, here in India, we're mainly concerned with two of the most notorious members of this family. First, we have Plasmodium vivax. This is the sneaky one. It can hide out in the liver and cause relapses months, sometimes even years later. And then we have Plasmodium falciparum. This is the real killer. It's the one that causes the most severe, complicated, and often fatal forms of malaria. Remembering this difference is absolutely critical, not just for your exams, but for your patient's life.
For many, many decades, we had one undisputed king in our arsenal, a true magic bullet against malaria. Its name was chloroquine. For your seniors, and even for me in my early days of practice, this drug was everything. It was simple, it was cheap, and most importantly, it worked like a charm. Now, what's really fascinating here is just how beautifully simple its mechanism was. Think about it. The parasite lives inside our red blood cells, and it's eating our hemoglobin for its food. This whole process creates a toxic waste product, something called heme. Now, the parasite is very smart. It's got a system to convert this toxic heme into a harmless pigment so it doesn't die. So what does chloroquine do? It just waltzes right in, builds up inside the parasite, and completely blocks that detoxification process. So the toxic heme just builds up, and the parasite basically poisons itself from the inside. I mean, that's brilliant, isn't it?
And for a long time, it worked wonderfully. It was a rapid schizenticide, which just means it killed the parasites in the blood very, very fast. A patient's fever would be gone, parasites cleared from the blood in just 1 to 3 days. But, and this is a big but, there was a catch. Chloroquine was completely blind to the parasite forms that were hiding out in the liver, those hypnozoids. So for PVVax, it could cure the immediate attack, but it could do nothing to prevent a future relapse.
But our enemy, the parasite, is not stupid. It evolves, it adapts, and pretty soon, our magic bullet started to fail. This is the central conflict of our story, the rise of drug resistance, especially in the deadly P. falciparum. So, how did the parasite fight back? It's actually quite clever. Imagine this. The parasite developed a tiny molecular pump thanks to a gene called PFCRT. This little pump sits there and its only job is to grab any chloroquine that comes inside and just throw it right back out. The drug can't build up to a high enough concentration, it can't block the heme detoxification, and poof, it becomes useless. And you know, this wasn't just some theoretical problem in a lab. Look at this data from our own country. In Northeast India, resistance rates just shot through the roof, as high as 83% in some places. The drug was failing almost everywhere. This forced our national body, the NVBDCP, to make a really drastic decision. It was time to abandon our old king, chloroquine, and switch to a completely new strategy for falciparum malaria nationwide. The failure of using just one drug, what we call monotherapy, taught us a very, very important lesson. When you're fighting a clever, adaptive enemy, you can't rely on a single weapon. You have to attack it from multiple angles at once. And that's how the era of combination therapy was born. Which leads us to the obvious question, doesn't it? If chloroquine is no longer our champion for falciparum malaria, what is? Who is the new hero leading the charge in this fight?
Meet artemisinin. This compound and its derivatives, they come from a plant that was used in traditional Chinese medicine for centuries. They are the most rapid and potent blood schizanticides we have today. They are brutally effective against P. falciparum, clearing parasites way faster than any other drug we have. This, right here, is the cornerstone of our modern strategy.
And this slide right here, this is the modern game plan. We never use artemisinin alone. That would be foolish because the parasite could just develop resistance to it also. Instead, we use artemisinin-based combination therapy, or ACT. The whole strategy is to combine the super fast-acting artemisinin with a much longer-acting partner drug. So artemisinin delivers the quick knockout punch, and the partner drug sticks around in the body longer to mop up any stragglers. This two-pronged attack ensures a complete cure, and just as important, it protects our best weapon from becoming useless.
So, we have our strategy for the parasites in the blood. But that's not the whole story, is it? What about those sneaky guys hiding in the liver? And what about stopping the patient from spreading the disease to others? For this, we need a specialist, a special agent with a very particular set of skills.
And this special agent's main mission is something we call a radical cure. This is a key term, so please note it down. Radical cure doesn't just mean treating the current fever. It means eradicating every single parasite from the body, both the ones active in the blood and those dormant hypnozoids in the liver. This is the only way to truly prevent a PVVAX relapse.
And the drug for this special job is Primaquine. It is unique. It has two absolutely critical missions that no other drug can do as well. First, for VVAX malaria, it kills those dormant liver stages, giving us that radical cure. Second, for falciparum malaria, just a single dose kills the sexual forms of the parasite, the gametocytes. Now what does that mean? It means the patient can no longer infect the mosquito that bites them. It breaks the chain of transmission. It's both a cure and a public health tool all in one little tablet.
Now everyone, listen carefully. Put your pens down. This is a very, very important point. A non-negotiable rule. Primaquine has a dark side. In patients who have an enzyme deficiency called G6PD deficiency, this drug can cause a massive, life-threatening destruction of their red blood cells. We call it hemolysis. You must, I repeat, must, screen for this condition before you prescribe a full course of Primaquine. This is one of the most important safety checks you will ever learn. Don't you ever forget this.
So, let's put it all together. Where do we stand today in our fight against the most dangerous form of malaria in India? What is our gold standard? TK, let's see. The national policy is crystal clear, and you must know it by heart. For any case of uncomplicated P. falciparum malaria anywhere in India, the first-line treatment is artemisinin-based combination therapy, full stop. Using artemisinin by itself, monotherapy, is strictly prohibited. And why? To protect our most valuable drug from resistance.
Okay, class, let's summarize for your exams. 4 simple points to take home from today. 1. Chloroquine, our old king, is out. No longer used for falciparum malaria because of resistance. 2. ACT is the new king, the undisputed first-line treatment. 3. The strategy is always combination therapy. Hit the enemy with 2 drugs, not 1. And 4. Never ever forget our special agent Primaquine for its unique, vital roles in curing VVAX relapse and blocking falciparum transmission.
And that brings us to the end of today's lecture. We have our strategy for now, but I want you to remember, the parasite is always evolving. There are already worrying signs of artemisinin intolerance emerging in Southeast Asia. So the final question I'll leave you with is this: what's next? What will be the weapons for your generation of doctors? Because believe me, this battle is far from over. Okay, class dismissed. And make sure you read Chapter 61, Part 1 thoroughly for your internals. Go on.
Good morning, everyone. Cello, let's get started. Today, we're going to talk about 2 microscopic enemies you will see all the time in your practice: the parasites that cause malaria and amebiosis. Now, understanding how we fight them with drugs is absolutely crucial, so pay close attention.
So, here's our game plan for today's class. First, we'll tackle the big problem of drug resistance in malaria. Then, we'll look at our brilliant counterattack. After that, we're switching gears to amebiasis, a much sneakier opponent. And we'll discuss its very special treatment strategy, focusing on one drug you absolutely have to know inside and out. Okay, so first things first. For many years, we had some pretty reliable drugs for malaria, but the parasite, especially the really dangerous one, Plasmodium falciparum, is very smart. It's fought back, and now we have a major clinical problem on our hands. So I want you to just think about this for a second. Why? Why would a single powerful drug that used to work perfectly just stop working? What's going on at a biological level? The answer, as you probably guessed, is resistance. It's simple evolution, really. When we hit the whole parasite population with just one drug, we accidentally create a survival of the fittest scenario. The few parasites that happen to be naturally resistant survive, they multiply, and soon the whole population is resistant. That's why using just one drug, monotherapy, is now a recipe for disaster in falciparum malaria. But this is where pharmacology gets really clever. When you're faced with an enemy that can adapt, you don't just find a new weapon, you develop a whole new way of fighting. Let's look at this brilliant counterattack strategy.
And that strategy is called artemisinin-based combination therapy, or ACT. Please remember this name. It is the global standard now, recommended by the WHO for all uncomplicated falciparum malaria cases. The idea is simple but so powerful. Never fight the enemy with just one weapon.
This slide shows perfectly how it works. I want you to think of it like a 1-2 punch in boxing. First, the artemisinin drug comes in and acts super fast. Bam! It knocks down more than 95% of the parasites. This is what makes the patient feel better so quickly, but we're not done. Then comes the second punch, the longer-acting partner drug, which stays in the body to mop up any remaining survivors. The key is, by using 2 different drugs at once, it becomes almost impossible for the parasite to develop resistance to either of them. It's a genius move.
Now this is pure practical knowledge for you. These are the main ACTs you will be prescribing here in India, and the small details matter. For artemether lumefantrine, you must tell your patient to take it with something fatty, like a glass of milk or with their meal. If you don't, it just won't get absorbed properly. ASS/P is the first choice for our national program in many areas, but you have to be aware that there are reports of resistance, especially in the northeastern states. And DHA piperwarquine is another fantastic, very safe option.
All right, Chalo, let's shift our focus. We're moving from the bloodstream to the gut. Our second enemy for today is Entamoeba histolytica, the parasite that causes amoebiasis. And this one is a master of disguise. And this picture captures the whole problem perfectly. The parasite has 2 faces, you see. It can live quietly inside the intestine, in the lumen, forming cysts which are passed in the stool. This is the luminal cycle. But then it can turn nasty. It can become invasive, digging into the wall of the intestine, causing ulcers and bloody dysentery. It can even travel through the blood to the liver and cause a life-threatening abscess. Same organism, 2 very different behaviors.
And this is a massive public health issue for us in India. Think about it. Around 15% of the population is infected. But here's the catch. Most of them are asymptomatic cyst passers. They feel perfectly fine. They have no idea they are a walking, talking reservoir for the disease, silently spreading the infection to others through contaminated food and water.
So because our enemy has this dual nature, our treatment strategy has to be dual as well. It's not enough to just treat the sick patient who comes to you with dysentery. We have to deal with the source of the infection too.
I want you to think like a military general for a moment. You have enemy soldiers inside your city fortress, causing chaos. But you also know there's a hidden enemy camp outside the city walls, ready to send in more soldiers. How do you win this war? You can't just fight inside, can you?
Exactly. You have to fight on 2 fronts, and this is our pharmacological arsenal. We have tissue amoebicides. These are the weapons for the invaders inside the fortress, the ones in the intestinal wall and the liver. Then, we have luminal amoebicides. These are for the hidden camp outside, the cysts and trophozoites that are just hanging out in the gut lumen.
So this is the most crucial point, and I want this burned into your memory. For invasive amoebiasis, you must fight a 2-front war. You give a tissue agent to cure the actual disease, but you must follow it with a luminal agent to clear out the reservoir of cysts. If you forget that second step, I guarantee you, the patient will come back with a relapse, because the source of infection is still inside their own gut.
Okay, now let's zoom in on the most important tissue amoebicide we have. This is a drug you will prescribe again and again and again in your career for many, many things. It is the absolute workhorse of our pharmacy, metronidazole.
Just look at the range of this drug. It is incredible. It's not just for amoebiasis. We use it for giardia, for Trichomonas vaginitis, and, very importantly, for infections caused by anaerobic bacteria. It's even a key player in the cocktail of drugs we use to get rid of H. pylori and peptic ulcer disease, a truly versatile drug. But it is not a perfect drug. It has side effects, and you must counsel your patients properly. Nausea is very common, and they will often complain of a very strange metallic taste in the mouth. But the most important warning you must give them is this. They must strictly avoid alcohol while taking this drug and for a few days after. It causes something called a disulfiram-like reaction, which is extremely unpleasant. They'll get flushing, vomiting, a terrible headache. No alcohol, period.
Now, metronidazole has a newer cousin, tinidazole. The big advantage here is all about practicality and patient comfort. See, it has a longer half-life.
This means instead of taking it 3 times a day, the patient can often just take it once a day. It's generally better tolerated with fewer side effects, and what does that lead to? Better compliance. And better compliance is the key to a successful cure.
So we'll end our class here today, but I want to leave you with this thought. We have these clever strategies, right? The ACTs, the two-front war, but the parasites are always evolving. This battle is never really over. It's a constant arms race. So, as the next generation of doctors, you must always be thinking, what's next? What will our weapons look like in 10 or 20 years? Something to think about. That's all for today.